there. He's on the screen there, not on the screen there. We'll figure that out. They'll be presenting the prevention of SARS-CoV-2 infection in children using cohort and population-based administrative data. So like COVID-19 public health interventions. And I've known Mary and Jonathan for a very long time. Mary is a PhD candidate in Epi at U of T, and this is part of her thesis work, which she'll tell you more about. And she's a two-time recipient of the CIHR Patient-Oriented Research Award, was previously an epidemiologist at St. Michael's Hospital. I know her through her amazing work in Target Kids. And then previous to that was at CHEO. And this work has been funded in part through a Leong Center seed grant with population health at U of T. So I'm thrilled about that. And then Jonathan McGuire is a senior scientist, professor of pediatrics at the MAP Center for Urban Health at Linka Shing Institute, Department of Peds. And he is also a law student chair in patient engagement and child nutrition in University of Toronto. And I'm thrilled to have them both here, and I'll moderate questions after. So welcome.
Thank you. Thank you very much, Catherine. I hope you all can hear me. I just wanted to say a few words before we get going. Mary's going to tell you a wonderful story about COVID in children. And just to put things in context, March 17th was the declaration of emergency of COVID in Ontario in 2020. And, we run Target Kids Practice-Based Research Network, Catherine and I. Everything was shut down. There were no kids going into clinic. And, for research networks that are based in the practice, that's a pretty difficult thing. So, we were left with a choice of shutting everything down, which we did, or changing our view for a little while to focus on COVID, because that's what was going on all around us. And I think within the first week or two of April, we had received one grant that helped us get going, and then several more that's led to this work that Mary's going to tell you about. So just a huge shout out to the entire team for doing this during COVID-19. Catherine and I, we worked tirelessly, and so did the rest of the team, to maintain things in the research network. We didn't lose a single staff person because of the pandemic, because we had to let them go. Because we focused on the work that Mary's going to tell you about. So just congratulations to everybody, and lovely to see this all come together. And here's to Mary.
Great. Can everyone hear me? This is the first time using one of these. Okay, hi everyone. My name is Mary. I'm a PhD student over at the Dalalana School of Public Health. Thanks, Jonathan and Catherine, for the introduction. So the title of my talk today is Prevention of SARS-CoV-2 Infection in Children using Cohort and Population-Based Administrative Data to Evaluate COVID-19 Public Health Interventions. And this is a project that's very near and dear to my heart, because not only did I begin my PhD in epidemiology during a global pandemic, but I also had my first child during the pandemic as well. So this is research that I see not only through the lens of a researcher, but as a parent as well. So for the agenda today, we're going to be talking about 3 distinct projects that I'll be working on during my thesis. So the first is seroprevalence of infection-acquired and vaccine-acquired antibodies. The second is vaccine effectiveness of mRNA-1273, that's the Moderna vaccine, in young children. And then the third is looking at the impact of non-pharmaceutical interventions on SARS-CoV-2 infection. But I think some of my favorite talks have always sent me home with a few principles to consider for my own research. And so I'll throw those up here. So first, descriptive studies can be really important. So as researchers, we often sort of default sometimes to these fancier methods, but I'll explain in my own, in my own first study that having some basic descriptives can really change the way you think about your research going forward. Secondly, we're still innovating in observational study designs. So we know from FE 101 that we're talking about the cohort study, the case control study, the case series, but there's still innovations happening here. And often having to do with the nature of the data that we collect, or the nature of the data that we have available. And we should keep our ear to the ground for them. And I'll show you a new innovation in my work. And finally, with time-varying exposures or time-varying confounding, traditional methods often fall short. So any exposure that doesn't remain static over time, traditional methods won't work and will often highest results. And I'll explain that to you a little bit later and explain to you how we might go about solving that issue. But first, I'm going to take everyone back to the beginning of the pandemic. And this article here is from March 2020, so 5 years ago now, if you can believe. And parents were being bombarded with headlines and images such as this one. And at the time, information was very new and very alarming. And so it was a lot of fear and uncertainty for parents and, raised significant concern about the impact of the virus on their kids. And because this was a global crisis, we didn't know very much about the nature of this virus. We really threw everything we had at this problem. And so we did things like pharmaceutical interventions, such as vaccinations. We did non-pharmaceutical interventions, which I will refer to as NPIs. And those included community level ones, such as school closures, stay-at-home mandates, as well as individual interventions such as physical distancing, washing your hands, wearing a mask, staying home, limiting the visitors in your home. But we know that each of these interventions had their own repercussions. So for example, school closures meant social and educational problems for children. Social distancing meant that children couldn't play with their friends, which led to for their social development. Masking was really challenging for children, and staying home had a lot of repercussions for families, social and economic repercussions, especially, particularly for women. So now we are in 2025, and now that the pandemic is for the most part behind us, it is time to look back and really evaluate what worked and what didn't for our children. Because we currently do not have a record that stands in time of the impact of all of these interventions on the thing that they were meant to prevent, which is COVID-19 infection. And if and when we encounter the next pandemic, people should be able to look back and say, here's what worked for kids. So the objectives of my thesis, of my body of work in my thesis, are really to create that record that stands in time and fill in those gaps. So one of the first things I'd like to do is quantify the extent to which children were infected during the pandemic. So that's describing the seroprevalence of SARS-CoV-2 antibodies. Second, I wanted to determine the initial impact of mRNA-1273 against symptomatic infection and hospitalization. So that's looking at a pharmaceutical intervention. And third, I wanted to determine the causal impact of non-pharmaceutical interventions. So in particular, masks, social distancing, and staying home on infection. And I will describe that in a later slide. But first, let's talk about our data sets. So many of you know CHES, which is a research institute that securely collects and analyzes vast, linkable health and social data from across the province. I'll also be using Target Kids, so data from Target Kids, which is Canada's largest children's cohort study with over 14,000 children. So during the pandemic, Target Kids was able to quickly pivot and recruit 1,400 children and their families to regularly report their adherence to things like non-pharmaceutical interventions, such as masking, social distancing, staying home. And we called this the COVID-19 study of children, the Target Kids COVID-19 study of children and families. We also collected valuable information on parent-reported infection, either by PCR or rapid test. And we collected this information regularly, so weekly during the first few months of the pandemic and then quarterly after that. And to our knowledge, this is one of the only data sets in the world that have been able to capture COVID-19 pediatric data at this level. So very few groups were collecting longitudinal data on NPI adherence. And we are one of the only groups to capture NPI adherence in children. So off to our first objective. Oh, that's why it's unique. So after our first objective, so seroprevalence of SARS-CoV-2 antibodies among children receiving primary care in Toronto. So before we start evaluating interventions, it's important to get a good idea of the scope of the problem. So how much infection was there? Now, we know that provincial testing isn't a good indicator for a couple of reasons. It relies, first of all, on people actually going to get tested, which might be harder for those without easy access to testing. It was symptom gated, so you had to have symptoms to get a test, and many children had mild or asymptomatic disease. And testing was very restricted till the end of 2021. The seroprevalence studies are a good way to quantify the burden of disease. And so there have been studies in British Columbia that showed that seroprevalence reached about 42.3% by mid-2022, and in Montreal, where it was as high as 58% by mid-2022. However, when it comes to Ontario, there was a significant gap in our understanding. So starting in January 2021, we began inviting children from newborns up to 16 years old to take part in a unique effort to track COVID-19 infections using at-home blood testing. The families received dried blood spot kits in the mail, which included easy-to-follow instructions on how to collect a small blood sample from their child, how to safely store it, and how to send it back to the lab. And what made this study special is that we encouraged quarterly samples, giving us a rare, ongoing glimpse into how immunity was changing over time in this population. So recruitment remained open during the study period, allowing us to continue to build the cohorts, and in the end, 475 children took part, contributing to what we believe is one of the few longitudinal pediatric COVID-19 seroprevalence data sets in Ontario. And here's our seroprevalence graph. So on the x-axis is calendar date, and on the y-axis is seroprevalence of infection-acquired antibodies. So we observed a clear rise in seroprevalence over time, so 2.6% from January to June 2021, 7.7 from July to December 21, and then a sharp increase to 43.1 from January to June 2022, and finally 50.7% from July to November 2022. And that steep rise between late 2021 and early 2022 coincides with the emergence and rapid spread of the Omicron variant, which was far more transmissible than previous strains and led to widespread infections, particularly in children. Now, when we look at vaccine-acquired antibodies, so that's this middle graph here, we also see a clear upward trend from just 1.46% in January to June 2021 to 45.21% by July to November 2022. And this trajectory closely aligns with provincial vaccine rollout timelines. So children aged 5 to 11 only became eligible for the vaccine in November 2021, and children under 5 years weren't eligible until late July 2022. So the rise we see in our vaccine-acquired antibodies reflects both the timing of vaccine approvals as well as the age distribution in our cohort. And the next graph shows the proportion of children with evidence of either infection-acquired or vaccine-acquired antibodies. So by November 2022, roughly 80% of children in our study had some form of immune protection against the virus that causes COVID-19. So what we see captured by provincial laboratory testing, which was about 220,000 by mid-2022, is only a small part of the real picture. So our study shows that far more children were actually infected. So by mid-2022, more than half had infection-acquired antibodies compared to only 8.8% detected through lab testing. So this gap shows that many infections went underreported, likely due to limited testing access for children during the pandemic. And so descriptive studies are important because they help uncover these hidden patterns, providing a clearer understanding of the true impact of the virus and guiding better public health decisions. Okay, so I'm going to go on to objective 2. So now I want to talk to you about vaccine effectiveness. So this is looking at vaccine effectiveness of mRNA-1273, also known as Moderna, in young children. So in particular, we were looking at the outcomes of symptomatic infection and hospitalizations. So just as a quick review, vaccine effectiveness studies set out to look at the real world effectiveness of a vaccine. So not under perfect clinical trial conditions, but how the vaccine does in a sort of wider pediatric population. And there have been a number of studies that show that mRNA vaccines are effective in reducing symptomatic infections and hospitalizations in children aged 5 and up. However, I can count on one hand how many studies are looking at vaccine effectiveness in children under the age of 5. So there's still a need for more research on how these vaccines perform in younger children, particularly in less severe outcomes such as symptomatic infection. So in an ideal world, if we want to do a vaccine effectiveness study, we would conduct a prospective cohort study. We'd recruit children, follow them up over time, and then surveil them daily to see who got infected with SARS-CoV-2 and when. This sounds simple, right? The problem is that this is really, really resource intensive. So you need to follow a lot of children to have precise estimates, and you need to test these children every day. And even if you tested them weekly, this can mean thousands and thousands upon PCR tests. And you will probably have a hard time finding families and children who are willing to do this. So, okay, so cohort studies are too expensive and people don't want to participate. What's the next best thing? So the next best thing might be a population-based case control study. So our cases are ascertained from hospitals, pharmacies, testing centers. But where are controls coming from? So this is challenging because if we were to sample from the larger population, well, we know that those who show up to get tested are different than those who don't in terms of access, sociodemographics. So we really can't sample from the population at large. So we think, okay, what if we just limit our study to those who got tested? This feels like a fix. So it evens out the access issue. So everyone in the study had access to testing and used it. So now we're at least comparing those who had navigated the same system. But we're not out of the woods. And that's because what we actually want is for our cases and controls to come from the same source population, and that's not guaranteed here. And the reason is, the reason for testing may differ between the groups. So cases are often tested because they actually have symptoms. Controls might have gotten tested for other reasons, like they had routine screening, or perhaps they were exposed to a family member. So we're still comparing different types of people, even though they all got tested, which reintroduces bias. And that brings us to the test negative study, which is considered an innovation in epidemiology. And, you know, while the test negative design has been in use since the early 2000s, especially in flu vaccine effectiveness studies, it was only formalized in 2013 by a pair of authors named Jackson and Nelson, who clearly defined the test negative study design and its assumptions. And essentially what happens is we compare symptomatic test positives to symptomatic test negatives. And we compare the vaccination status, and if the vaccine is effective, we'd expect a higher proportion of cases to be unvaccinated and a higher proportion of controls to be vaccinated. And so that's what we did. We used administrative data sets from ICES, and what we did was we looked at all symptomatic community dwelling children who presented for COVID-19 testing between July 28, 2022 and December 3rd, 2022. And we separated those children into two groups. Either they were symptomatic test positive, so they were cases, or they were symptomatic test negative, so they were controls. We had a number of exclusions, including those who were immunocompromised, those receiving another type of vaccine. And what we found was evidence of protection against symptomatic infection in the early stages of vaccine rollout. So this graph shows vaccine effectiveness on the y-axis, with the 0 line indicating no effectiveness, and the x-axis displaying our different exposure groups. So 1 dose and 2 doses, with timing accounted to allow for an immune response to develop, So as you can see, after 2 doses, vaccine effectiveness reaches 90% against symptomatic infection, which is statistically significant. So you can see that with the confidence intervals not spanning the null. In contrast, effectiveness after just 1 dose is around 20%, with confidence intervals that include the null, indicating no significant protection from a single dose. Let's now look at protection against COVID-19 related hospitalizations. So this graph again shows vaccine effectiveness on the y-axis and our dosing groups on the x-axis. So we observed 82% effectiveness against hospitalizations after 2 doses with a confidence interval that doesn't span the null. For 1 dose group, the vaccine effectiveness was around 58%, but the confidence intervals do span the null, suggesting no clear evidence of protection. So similar to symptomatic infection, we see evidence of protection after 2 doses, but not after just 1. So in conclusion, we now have estimates of vaccine effectiveness against both symptomatic infection and hospitalizations in young children. So our findings are consistent with studies conducted in older children in Ontario. However, ongoing monitoring is essential as our study only captured the first 5 months of the vaccine rollout. And there are broader challenges with conducting vaccine effectiveness in sort of the post-pandemic era. While the test negative study has been effective historically, the decline in publicly funded testing for children really limits its future utility. So moving forward, we'll need to stay attuned to emerging methodological innovations or ideally secure better funding to support the collection of some high quality data here. So now we're on to objective 3, the last objective. So this one I'm currently working on analyses as we speak. So stay tuned. So even 5 years into the pandemic, we still don't have a clear understanding of which individual NPIs are effective at preventing infection in children. So while some strategies may offer more protection than others, consistent adherence can be especially difficult for families with young children. And when we look at the existing literature, most of the data focuses on community level interventions, so like school closures and school closures on overall infection rates in the population. But there's still a significant gap when it comes to understanding the impact of individual level adherence on a child's personal risk of infection. So this project was designed to sort of emulate an intervention. So to ask a what if question. So what if we could go back in time and change how many days per week children wore masks, stay home, or physically distance? What impact would that have had on their risk of infection? So these kinds of counterfactual questions are important for guiding real-world decisions about protective behaviors. So we're linking 2 powerful data sets, ICES and Target Kids, to bring together really rich longitudinal behavioral data with comprehensive administrative health records. So our primary outcome is SARS-CoV-2 infection, either identified through 2 sources, either RT-PCR tests from the Ontario Laboratory Information System or parent-reported infection from the Target Kids questionnaire. And our exposure is adherence to NPIs over the last 7 days. So parents were asked weekly, of the last 7 days, out of the last 7 days, how many days has your child been practicing the following preventive measures? So this is some preliminary work we conducted looking at data from April 2020 to April 2021 to explore whether adherence to NPIs was associated with test positivity for SARS-CoV-2. So our question really was, can NPI adherence help identify children at higher risk of infection, sort of beyond traditional risk factors? So the aim here wasn't to determine whether NPIs caused a reduction in infection risk, but rather to explore whether adherence might serve as sort of a useful indicator for targeting prevention efforts. Interestingly, if you look at the table here, we found no association between NPI adherence and infection in this analysis. And you can see that in this table with hazards ratios spanning the null. And why might that be? Well, this framework, we have to remember, is different. So the study wasn't really built to assess causality, and trying to use these methods to answer a causal question would introduce bias. And so we need to use a different approach. So I want to share another set of results with you. So this work that we did on the Target Kids COVID-19 data in 2022. So in this graph, the x-axis shows calendar dates from March 2020 to November 18, 2021, and the y-axis represents a summary score of total NPI adherence. The black line shows results from piecewise modeling, while the blue line represents a Loess curve. And what's striking is how NPI adherence fluctuates over time, especially around key events like school closures and reopenings. So for example, when schools closed on December 21st, 2020, you could see that adherence shot up. But when schools reopened on February 16, 2021, you can see a noticeable drop. And the key takeaway here is that adherence is not a static exposure. It changes in response to public health policies and context. And to treat it as fixed in analysis would really miss the reality of how families actually behaved during the pandemic. So here's the challenge. So this is a dialectic graph or DAG showing the causal relationships. So Z is the set of time fixed covariates, things that don't change over time. So that's things like child age at baseline, sex, parent ethnicity, household income, etc. L is a set of time varying covariates. So that's number of cases in the community, vaccination status. And we're interested in the causal effect here of physical distancing on time to infection. And just to be really clear right up front, when we say the causal effect of physical distancing, we don't mean the effect of distancing at just week 1 or day 1. We mean the joint effect of a sustained physical distancing strategy over time. So as if children consistently distanced every day versus if they never did. So we're comparing whole patterns of behavior and not isolated moments. And what we see is that physical distancing at time 1 can affect, so let's pretend that L is number of community infections. So we can see that physical distancing at time 1 can affect number of community infections at time 2, which in turn impacts physical distancing at time 2, which then impacts number of community infections at time 3, and the cycle continues. So here's the problem. So the number of community infections at time 2 is both a mediator, so it's on the causal path from physical distancing at time 1 to infection, and it's also a confounder because it affects both physical distancing at time 2 and infection. So this is a challenge because we need to adjust for number of community infections at time 2, but it's a mediator, and you can't adjust for mediator without blocking part of the effect you want to estimate. But you also can't leave a confounder adjusted without bias, so we're stuck. So unless we use methods specifically designed for this kind of time-varying structure, we can end up with bias. And that's where the parametric G formula comes in. So the parametric G formula was formalized by an epidemiologist named Jamie Robbins in 1986, but really wasn't available to researchers at the time because they lacked the computational power. However, now in 2025, we now have the ability and packages to help us do this. So researchers often use standard regression modeling to adjust for confounding, but when some of those confounders are also causal intermediates, so on the path between your exposure and your outcome, this amounts to adjusting away some of the effects of the exposure. So the parametric G formula works differently by using standardization, which lets us find an unconfounded measure of effect without running into the issues of causal intermediates or feedback loops. So when thinking about our question, which is really trying to find the impact of these NPIs on infection, a really complicated scenario, we can take advantage of some of these methods. So we're going to use the parametric G formula, which is a form of standardization that can be used to address time-varying confounding in causal inference with observational data. So it uses simulations that mimic standardization to create a population that represents the counterfactual. And it works by three main steps. So modeling the conditional distributions, sampling from those distributions, and then averaging across averaging results across the simulated populations. And I'm going to go through each of these steps as simply as possible. But I will tell you, by going through these simulations, you're essentially creating two weighted averages that can then be compared, so taking care of all of the confounding that you're worried about. So the first thing we're going to do is model the conditional distribution. So think of this step as creating a weighted coin. So using your existing data, you're essentially building a weighted coin for each time varying covariate exposure and outcome at each time point. And these coins reflect the probabilities of different values given a person's history up to that point. Now you're going to use these coins to create a pseudo population. How? So that's done by sampling from your data and then calculating expected values for each outcome and time varying covariate at every time point. So in this first run, you simulate a world in which children were adherent to treatment 0 days a week. So not adherent at all. You do this 1,000 times, flip your weighted coins to simulate what would have happened. And in the end, you get a pseudo population that mirrors what the outcomes would look like if no one ever adhered. And then you do it all over again, the same process, same data, but then you simulate a world in which children were adherent every single day. So it's like testing out a public health intervention that ensures perfect adherence and watching how things play out in your simulated world. Finally, all that's left to do is compare these two pseudo populations. So in my case, I'm going to be using a cost proportional hazards model to compare the outcomes between the two groups. And here's the best part, because you've already adjusted for all of the confounders in your modeling, your comparison is now completely standardized. So what does this mean? Well, this might be one of the first studies to examine individual level NPI adherence on SARS-CoV-2 infection. So hopefully armed with the right data sets and the right methods, we can get started on doing the very difficult work of at least trying to quantify some of the impact of masks, social distancing, and staying home on infections. Again, I think we deserve to have an evaluation of what worked and what didn't for future pandemics to come. So some key takeaways. And so more than half of children had evidence of SARS-CoV-2 infection by November 2022. Initial effectiveness of mRNA, so over half of children were infected. This far exceeds lab-confirmed case counts, and this highlights the value of descriptive seroprevalence studies and in uncovering hidden trends. Real-world protection, so 2 doses of mRNA 1273 vaccine offered strong early protection against both infection or symptomatic infection and hospitalizations in children under 5. And this supports extending vaccine restriction monitoring to pediatric groups. And finally, traditional methods fall short when exposures and confounders change over time. So advanced causal inference methods like the G formula are essential to understanding real-world policy impact. And looking ahead, so future pandemics will come, and so we owe it to children and families to know what worked and what didn't. So thank you so much. That concludes the presentation. I'd like to thank my lab, Target Kids, which has made this work possible, and all the families who participated. I'd like to thank Dr. Jonathan McGuire, who's been the most incredible mentor throughout my PhD journey, my co-supervisor, Jeff Kwong, who has led me through all of the intricacies of using ICS data, and of course, all of my committee members and mentors. And that's it. Thank you so much. Happy to take questions now.
Thank you so much, Mary. I don't know, Jonathan, if you have any other comments, or I can start with a question.
Yeah, thanks, Catherine. Just really appreciate everyone's time today and to congratulate Mary on this phenomenal work. As Mary points out, it's complicated, and but I think we owe it to our kids to answer these questions. Nobody else seems to be answering the questions. You can imagine, we all knew, kids paid a big price for what happened, and did it pay off? Was it good? And I think we need to provide answers to that. So congratulations to Mary to taking on a really important but difficult challenge.
Yeah, I'd like to say that as well. I mean, I think we've published some research looking at change in these exposures and other outcomes like mental health of children, screen time use in children, BMI in children. But maybe our approaches have been a bit simplistic. So having other approaches to better understand the repeated exposures might be really helpful for us. So maybe a philosophical question, because you've used data from ICS, administrative data, and you've used data from sort of individual collected data. If you were to sort of, God forbid, go back to the beginning of COVID, like what kind of system would have put us in a better position to answer your research question? And then I'll take questions from the audience.
Yeah, that's a really hard question. So I'll give the example of Target Kids. So Target Kids actually did an amazing job of sort of pivoting. So we were able to take, the Target Kids cohort, and from there, we had the infrastructure to start to recruit families and children who had already been in research and were willing to participate in research. So sort of like, the cause of helping the pandemic. So this was really good. I think taking advantage of cohorts that already exist, particularly with children, is amazing. We also, so during the beginning, I think we had PCR tests that we were giving out every single week, right? And trying to get children and families to provide these PCR tests every single week. And that was great, However, there was two problems with that. First of all, the virus wasn't really reaching children and families really early in the pandemic. So we didn't actually capture a lot of infection until, the beginning of 2022. And so if we had continued that, it would have been wonderful to be able to sort of capture infection in all children within this sample, rather than having to rely on provincial laboratory testing data. Of course, you run into issues such as, parents' willingness or children's willingness to actually do the test. So there's some intricacies there, but I think leveraging existing data sets for children is a good start, as well as connecting it to some of this rich data that we already have.
And we really like a national or local system, which is okay. So questions from the group. Evan.
Just that really interesting work, Mary. A question about your third,
yes,
where you're looking at the NPIs. How does vaccination over the same time period factor into those analysis?
So vaccination would be considered a time-varying covariate, right? So we can get children who weren't, vaccinated at the beginning, but then later on they do. So that would be treated as a time-varying covariate in the analysis. So you would be putting that in at the time point that they were vaccinated. So it would be included in the simulation. It treated differently than time-fixed covariates, but yeah, I'm not sure that answered your question, Kevin. But yes, included.
I mean, you took that through the vaccines, example, dose 2.
Yes.
Effective, and if you've got, those in the NPI analysis, and any effectiveness really just from the vaccine, you might not have any room to see anything from social matters.
Right. So it's kind of nice because in the parametric G formula, it takes into account sort of the covariate history as well as the vaccination going forward. So when it simulates it, it's going to see that this person was vaccinated, and from there sort of create a pseudo population based on what we've seen in our previous data set in terms of being vaccinated and also doing the MPIs. I wish I had a better answer for you, Kevin. I'm gonna keep trying to. I'm gonna run this analysis and see what comes up. But yeah, it's something to consider.
Thank you. Is this your PhD work?
Yes.
Oh, yes, that's really excellent. You should have no problem getting through the PhD. My question really is about context and objective 2. And I would actually challenge you when you say that there's strong evidence of effectiveness related to hospitalization. Because if I look at the graph correctly, it looked like the boundaries were right from essentially 0 to 100.
Yeah.
So I'm not sure that it's fair to say there's strong evidence of.
Right.
And my second comment is, what were the rates of hospitalization in order, even if we say it's 2% well, lower bound 2% effective. How many kids were in hospital?
Yes, so definitely less than 5% in our studies. So in this group here, we definitely had less than 10 participants who were hospitalized. And you're absolutely right. These confidence intervals are very wide. And I think this reflects sort of the broader challenges of vaccine effectiveness studies in this age group. So first of all, very few children even went to go get the vaccine. So around this time, I think it was 4% of children had received the COVID-19 vaccine. And then second of all, not many of them get hospitalized. So you end up with really, really small numbers here. And so it again reflects sort of these bigger challenges in doing vaccine effectiveness studies in younger children. Yeah, but you're right, not too strong.
And very few hospitalized.
Very few hospitalized, absolutely. Thank you.
Thank you for the word and great presentation as well. I have two questions. One is on your first study. I don't think that you presented the proportion of people who actually sent back the samples over time.
Yeah.
And I saw that the confidence interval kept widening.
Absolutely.
And first, like how much of it? And then the question is, how do you think it is informative of what you've observed from regards to the finding?
Yeah, that's a great question. So let me put that graph back up. Yeah, so toward the end, you're absolutely right. We did get drop off of children and families sending back the dried blood spot kits. So we had 475 unique participants, but by this time point, we only had 75 children return the kits. And that's because, it's very difficult to get children to want to get poked. So even though there was a lot of effort from our side to try to obtain these samples, it did drop off toward the end, and you can see that these confidence intervals were a little bit wider toward the end. That being said, our study numbers here are very comparable to what we saw in BC and Montreal. So seroprevalence studies elsewhere, we're also showing very similar seroprevalence rates.
So you don't expect that there's some bias or
There always could be bias. Absolutely. You're absolutely right. I mean, yeah, there could be bias, but what we see here is consistent with what we've seen elsewhere in the country. And so, yeah, I think it's still relevant information.
Can I ask one more question?
Yes.
So in your third aim, so I have economists and I have a decision analysis.
Yes.
And I'm very happy when I see this kind of third aim parametric formula approach, because we have a tool we call microsimulation or agent-based modeling.
Neat.
And I wonder whether to me it looks very similar to what you're doing in your aim 3. I wonder whether you have experience and
Yeah.
similarity in your.
I have not explored agent-based modeling, but I know, sometimes it's like we speak different languages, but we're doing the same thing. So I'm glad to hear you say that, because I've heard of things like the parametric G formula happening in other fields, but it's only recently that I've been seeing it in epidemiology. So I'm glad to see that it's, being used elsewhere.
Eleanor, and then I saw a hand over here. Go ahead.
My question was actually related to Petrus's question, but more around the third project.
Yeah.
With the adherence to NPIs.
Mm-hmm.
And specifically around what was missing
Yes.
for the I was one of the
Yes.
putting this in, I know it wasn't perfect.
Yes.
And it was
Absolutely right.
with other stuff. So what was it like and how did you handle it?
Yeah, I'm still working on analysis now, but I know that, even from this seroprevalence study in, 2022, participation rates really started to drop. And so this is something I'm definitely going to have to consider, and I may have to, cut my data to the points where there isn't so much sparsity. So still, looking at that, and of course, everything we do is going to depend on the data that's available. And so we'll have to see what happens or what comes of this analysis.
Yeah. Do you think there's any danger of people gaming the system, like you asked for a 7-day week. Wow, we did X, Y, Z on Saturday, so I'm just gonna wait an extra few days.
Yeah.
Just want to float that as.
Yeah, definitely. There could definitely be some reporting bias happening in that.
Just waiting later to put up.
Potentially, yeah. It's really, really hard to tell. So one way that I'm hoping, well, yeah, it's really hard to tell. We're very reliant on the things that we actually collect from parents, and it's not a perfect instrument. I don't think anyone had a perfect instrument over the pandemic, but we're doing our best. But you're right, it's something to flag.
There are a few recent systematic reviews on evidence for appropriate or effective retention strategies in cohort studies, but there's very few studies that focus on children in these trials that to sort of improve retention. But things like reducing the burden, giving people cash for participation, having sort of engagement, like interest, handing them something at enrollment that stays with them throughout the study are sort of some effective approaches. But I think the more we can, help participants want to participate or be able or to participate long-term is really going to affect all of our work. But it's definitely a challenge as a participant, I'm sure, definitely a challenge. Okay, go ahead.
Hi, Mary. First of all, great seeing you and thanks for coming to speak with us. Timing is great. Last week, I just presented some of the stuff that we've done. And I think that, I have two sort of questions and comments.
Sure.
If
Please.
allowed. Some of the stuff that I talked about last week is some of the challenges that we've had with regards to biases, doing a retrospective cohort study, looking at vaccine effectiveness with an outcome of infection. And I do wonder if you're bumping into these issues when you want to try to assess NPI. And the reason for that is there is not only are there, mediation and confounders from time varying covariates, but also a relationship between your exposure and your outcome, right? So people who are more likely to adhere to NPIs are probably much more likely to get tested.
Absolutely.
And you probably your conclusion probably biased towards the null, and that's probably why you're not seeing any effect in your primary models, right? So I guess my question is, do you have a sense of, I may have missed that in the beginning, but like your definition for infection, it's like parent reported, does that PCR and rapid antigen detection test? And did you look at the characteristics of people who were tested versus people who weren't tested? And if there is like some sort of association between NPIs, and if you could account for potential sort of healthcare seeking / testing related behaviors?
Yeah, there's a couple of questions in there. No, absolutely.
I
Okay.
have two questions.
So the outcome is our RT-PCR and parent report of a positive test, either via RT-PCR or rapid test. So that's really important because I don't think there hasn't been very many studies capturing rapid tests here in Ontario. So it's really nice that we have that. That being said, people don't always report what they've done or the test that their child has overcome or undergone. One thing we're trying to do, and this is something that's supposed to be part of my third objective as well, is looking into sort of like a quantitative bias analysis and trying to see, we've got sort of these different ways of ascertaining infection now. We've got seroprevalence. We've got RT-PCR from OLIS, and we've got parent report, right? And it'd be kind of nice to see how that all differs, right?
That was my second question, 100%, like comparing your serosurveillance to your infection and see if it maps out nicely. Because your serosurveillance, we should be capturing all infections. You may have some bias.
Yes, exactly. I do expect some bias, and the question becomes how much is that bias going to impact my results? And so the plan is to hopefully do some of this interesting quantitative bias work where you see the difference between, what we've seen seroprevalence versus what is reported, and try to adjust your analysis based on that. Things become complicated because you're already dealing with a complicated analysis here. And then when you try to layer on some of this QBA stuff, it becomes even more complicated. But the first step really is to do the initial primary analysis and then try to see what the bias is after that.
But have you tried looking at like positive serology as an outcome and the association between that and the
Yeah, I mean, my outcome here is time 2. So seroprevalence is a kind of a difficult outcome for time 2 because it's sort of reflects like a prevalence rather than incidence.
Yeah, because that may be sort of more reflective of what sort of really happened because
Yes.
you're not sort of,
Yeah.
depending on testing rate.
Yeah, great question, great comment. Yes, although, I didn't have that many children in my seroprevalence study, so there was only 475, so it'll really limit my ability to do things, but yeah, great suggestion.
And there was just one last thing for
Yeah.
your second objective with
Mhm.
regards, I was a bit surprised to see compared to a previous comment, the high V that you had against infection,
Yeah,
which is sort of much higher than what we got in our TND.
yeah.
Children. So it's just were you able to look at waning at all or you?
We did. So we were able to look at waning after 1 dose. However, this group was, we cut it off at 5 months, right? So 5 months after vaccine rollout. So we didn't actually have a lot of numbers to be able to support waning after 2 doses. So we weren't really able to suggest that or to evaluate that in any robust way.
It's surprisingly high.
Yeah.
Maybe opportunities we have a lot of data, could be lots of opportunities to talk about other questions to answer, so
Right.
welcome that.
There's
Antonia.
a question in the chat.
Great.
Abdullah, if you can hear me, do you want to ask your question or I can read it out? So Abdullah asks, how did you encourage participation on seroprevalence patient recruitment? How are people incentivized to mail back TBS samples?
A good question, and Catherine, you might be better equipped to answer that than I am. But we,
I can take that, or Jonathan, do you?
Jonathan, you want to take that? So we did offer things like video conferencing to help parents navigate this dry blood spot system because it's not always intuitive how to, prick your child and get the sample. So we offered that. What else did we do, Catherine?
I think we had some funding support, but it wasn't necessarily every.
It's a really good question. Like early in the pandemic, parents were, eager to help. And so, people did it. And then as things dragged on, they didn't really want to help anymore. So I think that was perfectly understandable. Maybe we should have anticipated that a little bit more with some more incentives about this learning process. As Catherine says, getting people to do things is becoming increasingly difficult in our world, not just during COVID. So it's an ongoing challenge.
I guess some of the ways that we do this in general in our cohort is that the research assistants have sort of established relationship with practices, and that we try to innovate around that during COVID by having telephone calls, other ways to support participants. And a lot of the participants didn't, as all of us, didn't actually have a lot of support in general. So I think that was why we were able to continue on with the 1,400 participants throughout COVID. They had established relationships with the team members. They saw the research assistants as part of their, health team because they knew them before. So those were some of the relational ways. But when you look at the evidence of what is retention, all the things that we spend a lot of time on, like really nice newsletters and keeping people informed, like those are not necessarily highly successful. Those are like increase your retention by like 1%. The things that are highly successful should be obvious, like paying people for their time, making sure people know how they're contributing, what is meaningful to them, and then having some way to remind them that they are participating in a study and that they're contributing. So like something physical to hold on to seems to be one of the other strategies. So hopefully we can learn from this. Yeah, we have Eleanor.
Did you consider incentives for the kids? Because with the PCR, the biggest excitement in our house was the big paper clip that it came with. But and I can imagine, like with the blood spots, it's not the parent needs to be incentivized,
Yeah.
it's the kid.
But we use a lot of approaches now. We've done a lot of learnings. I don't know if you have answers.
No,
but you want me to
go
say-
ahead, Catherine.
So we now have some of our students made an amazing books for children's books. So when you're recruited to Target Kids, you actually have a book, which includes blood sampling. So that's really exciting. We now have fancy stickers and other, I think in those kits, we did hand out stickers with some of the kits and other ways for the children to feel part of it. There's some drawing competitions and things like that to help reward the children. But yeah, it's fun being creative, and we have parents on our advisory, so they advise all of these sort of interventions and give us advice about what they think will work and will not work. And having the parents' voice is huge. And we now have adolescents advisory committee as well that are engaged at all levels of the research process, and that's been a real game changer for us. We have 2 more minutes. Any last questions for Mary or Jonathan?
There is, Abdullah has his hands up.
Okay.
Sorry, it's a quick question. First of all, great talk, Mary. Thank you very much. Just had a quick question. How did you distinguish between vaccine versus infection-acquired antibodies?
This is a very technical question, Abdallah. So we used a very briefly, so we did look at anti-N and anti-spike protein. And we used a algorithm that was validated by a team over in Montreal. I can send you the paper. Yeah, very technical, and I'm probably not best poised to answer it.
I just wanted to know if it was molecular aspect to it, or if there was some direct answer on the actual blood spot test. But yeah, that answers my question.
No.
Thank you.
Yeah, there wasn't. No, it was ELISA based.
Okay. Okay, perfect. Thank you.
Okay, great. I wanted to thank Mary and Jonathan again for a great talk and amazing PhD work. Thank you.